Good afternoon, everyone. I welcome everyone for the post-lunch session. Our next panel discussion is on pancreatic duodenectomy, focusing on the post-operative aspects. I invite Dr. Paleswan J. Lakhe as moderator. Dr. Paleswan is professor and head of the Department of Surgical Gastroenterology at Tribhuvan University Institute of Medicine, Maharajganj Medical College, Kathmandu, Nepal. And also as a panelist, I invite Dr. Ram Daga, professor and head of the Department of Surgical Gastroenterology, SMS Hospital and Medical College, Jaipur. Dr. Sundeep Jain, consultant, GI and HPB surgery, Fortis Hospital, Jaipur. Dr. Yoji Kishi, HPB surgeon and professor of Department of Surgery, National Defense Medical College, Saitama, Japan. And joining us online will be Dr. Rebala Pradeep, senior consultant, Department of Surgical Gastroenterology, Asian Institute of Gastroenterology.
Thank you very much. At the outset, I would like to thank Professor V.K. Kapoor for the invitation and the hospitality. So I hope I'll make sure that nobody sleeps during this post-lunch session. And my job has been made easier by the previous moderator and the previous discussion. So some of the things may be repeated, but I'll make sure that it will be the pertinent things will only be discussed. So can we start? So one of our panelists wants to say something through the presentation. So he's downloading. So I think we should wait for him. So in the previous session, pancreaticoduodenectomy was, I bring greetings from Tribhuvan University Teaching Hospital, Kathmandu, Nepal. And in the previous session, pancreaticoduodenectomy was considered as a Ferrari, but most of the literature considered it as a Cadillac of abdominal surgery. And the mortality has decreased to less than 5% in high volume center, but morbidity is still high. And we all know that complications are part and parcel of any surgery and they are inevitable. But what is important is identification of these complications and managing them appropriately so that the downstream complications and the mortality does not happen. And it is very important to discuss complications because it defines the quality of surgery, and it is important to see what we are doing. And use of uniform language and comparison of results between various centers was emphasized in the first talk in the morning, and all the procedure specific complications of pancreaticoduodenectomy has been defined by International Study Group of Pancreatic Surgery. So the first 5 complications has been defined, and I will be basically focusing in these 5 complications. So these are our esteemed panelists, and I took all the pictures from the internet. I hope they are correct. So in 2005, the International Study Group for pancreatic fistula came up with the definition of postoperative pancreatic fistula. Accordingly, any measurable drain on and after day 3, which is more than 3 times the serum value, normal serum value, is considered as postoperative pancreatic fistula. And along with these 9 parameters, they are graded into A, B, and C. And as you can see here, grade A is actually does not have any clinically relevant change in the management, while in grade B and C, there is definite change in management and are considered as clinically relevant postoperative pancreatic fistula. But in 2016, this definition was updated because grade A was not considered as a complication. So it was considered as biochemical leak. And any patient who has persistent drain for more than 3 weeks, and there is requirement of percutaneous or endoscopic drainage or angiographic procedure required, or any signs of infection without organ failure, was considered as grade B fistula. And when reoperation was required or there was organ failure or death, it was considered as grade C fistula. And if you see in these illustrations, most of the biochemical leak and even grade B, they recover without mortality, while grade C, almost 40% of the patients, they die because of the development of multi-organ failure and sepsis and multi-organ failure. So I just want to ask actually all the panelists regarding whether they are following the IHPS definitions or not, and if not, then what they are following, specifically the POPF.
Since 2018, we are following these guidelines and we are seeing all our data according to all these guidelines.
Thank you.
Same for us. We are also following the case study as we follow the meetings.
Okay, so two of our panelists are online. I don't know whether they are with us or not. Dr. Pradeep Rebala and Dr. Vikram Chaudhari. So we at our institute are also following the same guideline, and the clinical implication of the 2016 definition was validated by this study from the Verona group, where they showed that the patients having no biochemical leak and patients having biochemical leak has similar reoperation, readmission, and major complication, as well as 90 days mortality and length of hospital stay. And they also showed that in terms of ICU admission and in terms of hospital readmission, length of hospital stay, and even the cost of treatment was significantly different in those patients who did not have POPF and those who had grade B and grade C fistula. And they suggested that this updated classification does have reliability in terms of clinical and economic outcomes. However, in certain subset of patients, like in this paper that was published in 2009, where they have quoted that around in 5% of patients, initially the drain amylase is normal, but in day 3 and day 5, but the patient's clinical course is not as expected, and the drain amylase is measured high only after postoperative day 10. And it has been seen that these patients have significantly worse outcome. And a similar finding was shown by the Japanese group in 2020, where around 10% of the patients did not have drain amylase elevated on day 3 and day 5, but was elevated in the later in 7th day or 10th day. And these patients are termed as latent pancreatic fistula. And this, they also showed that these patients had significantly worse outcome, higher incidence of PPH, intra-abdominal access, and the higher number of patients required re-intervention. So if you go through the literature, in 2007, there was a definition published by Steven Strasberg group, which is also known as PATH-POF system. And POF is pancreatic occlusion failure, that's for distal pancreatectomy, and pancreatic anastomotic failure. If you see here, in their definition, what they say is that when the drain amylase is more than 50 ml, and the serum and the value, amylase value is more than 3, the normal serum value on or after day 10 only, either in the intraoperatively placed drain or postoperatively placed drain. And they have graded they call it pancreatic anastomotic failure and not postoperative pancreatic fistula, according to the Clavin-Lindo grading system in 5 grades. So actually my question, first question is to Dr. Vikram Chaudhari, that what is the relevance of PATH-POF system that is described in 2007, and what is your experience regarding latent fistula? So can you check whether he's online or not, or anyone? Okay. So in our practice, do you have any experience regarding this?
We have occasional patients who have been discharged from our department, and they came back with some discharge from the home, which is causing some respiration. And these are patients who come with this PA or 2 week fever. So they are occasional patients, but if we are still having very small numbers, we cannot make out whether they do worse or better or same as normal temperature.
So are we?
It's online, but the camera is off.
So we can speak.
Yeah, it can speak also, but I think it's now in front of the.
Oh.
Yeah.
Yes, yes.
So he's here.
Vikram Chaudhary is there.
Good afternoon. Sorry, I got free slightly late from my theater. There was some delay and I had to change and I have joined finally. I'm very sorry to join late.
So the first question is for you. What is the relevance of PAC-POF system that was described in 2007, and what is your experience regarding latent fistulas?
So I would say the previous system is now very much updated. So the post-operative pancreatic fistula is now the hyperamylasemia is no more classified POPF-A, and mostly the clinically relevant pancreatic fistula is POPF-B and C. Is that what you mean to ask me, Dr. Am I
No, no,
missing something?
So what I wanted to ask you is that in certain subset of patients, the brain amylase is normal initially, but the clinical course is not as expected.
Yes.
And later on,
I think that is what was realized by ISGPS, and that's why they revisited their classification. Initially, all patients who on day 3 hyperamylasemia were universally classified as pancreatic fistulas, as POPF-A. It was unnecessarily documenting the hyperamylasemia as a fistula, which was actually not clinically relevant. So now I think we only document what is clinically relevant, and even I think any infected pancreatic fluid which is coming out is now becoming getting classified as a pancreatic fistula. So now the current classification is more relevant, and I think nobody now follows the old classification of a POPF-A. The classification is only CRPOPF, B, and C now.
Okay, thank you. So I think we need to keep in mind that certain patients will have normal brain amylase initially, and later on only it may manifest. And we need to keep in mind these patients while managing post-operative.
Can I make a statement? Yes, I did not address the second question. What about the latent fistulas? You probably meant that the day 3 amylase is normal, and these patients still develop clinically relevant pancreatic fistulas later. So that is the limitation of a day 3 amylase. So infected peripancreatic leak, which is either drained later in the drain or by your percutaneous intervention, that is more relevant. And a lot of patients do develop clinically latent or biochemically latent fistulas, which I would say. Yes.
Thank you.
And the clinical presentation is what is important.
Okay, thank you. So there are various risk factors for postoperative pancreatic fistula, which was a little bit touched upon in the previous session, and they can be categorized into preoperative, perioperative, and postoperative, and also as those factors which can be modified and those which cannot be modified. And there are various scoring systems which has taken into these factors, risk factors into consideration. And one is this original fistula risk score, where gland texture, pathology, pancreatic duct diameter, and intraoperative blood loss is taken into consideration. And it has got 4 risk categories. And in 2019, the Dutch Pancreatic Cancer Group came up with the alternative fistula risk score, which incorporates pancreatic texture, duct size, and the body mass index. And this can be calculated online. And this also tells us the mitigation strategy, not only the risk of development of fistula, but mitigation strategy as well. However, the same group updated the alternative fistula risk score by adding sex. And this was validated in the minimally invasive group, and later on in open pancreaticoduodenectomy as well. But the most highly cited is the original fistula risk score. And this was discussed previously. And as you can see here, that as the grade increases, the risk of clinically relevant postoperative pancreatic fistula also increases. And this is the ISGPS consensus classification. So I would like to ask Dr. Pradeep Rebala, if he is available online, that which scoring systems are you using in your clinical practice? And if yes, which one and why? So I think there are amongst the various scoring system, I think the ISGPS risk classification, which has been proposed in 2023, is more practical, on table, which takes into consideration the texture and the duct diameter. So does the panelist have any anything to comment on that?
Actually, our group do not adopt any of these predictive preoperative predictive scores because not the preoperative prediction, but the outcome itself would be important. So after POPF was confirmed, we need to take mitigation management.
So these scoring systems has been compared, and then this study where Dr. Vikram Chaudhari is one of the author showed this study showed that updated alternative fistula risk score was better than other scores. However, this another study from Japan showed that all the three scoring systems are equally has equal ability to predict the clinically relevant postoperative pancreatic fistula. And the ISGPS risk stratification was validated by the Dutch Pancreatic Cancer Group in around 4,000 patients. And as you can see here, that the number of patients in Group B, which is non-soft pancreas, and the duct diameter less than 3 is less in number. And the clinically relevant postoperative pancreatic fistula in Group B and Group C are almost same, and the hospital mortality are almost same. So they suggested that probably less is more, that instead of having 4 categories, 3 categories are better based on the number of risk factors. If there are no risk factors, then it's category A. If there is only one risk factor, either soft pancreas or main pancreatic duct less than or equal to 3 millimeters, it's category B. And if both the risk factors are present, then it's risk category C. And they showed that the predictive ability of both the 4-tier classification and 3-tier classification are equally fine. So maybe the more less is more, maybe 3-tier classification is better. So we will very briefly discuss about the various mitigation strategies. So I would like to ask Dr. Ram Daga regarding his mitigation strategy in terms of pancreatic anastomosis.
There have been a lot of studies comparing various customary techniques. There have been RCTs, meta-analysis, but none of techniques have been proven to be superior to other techniques in most of the times. So there are centers which come up with some techniques like bending technique. They have shown excellent results, but these results cannot be replicated in other centers. Similarly, other techniques like lump guard is not universally accepted still. So I think there is no specific technique which you can say that is better than other technique. Again, I think it's your technique which you have adapted, which you have learned from your mentor. You have to follow that technique in a precise way. You have to master that art, and then you have to follow that technique. This is what I believe. In our center, what we do, we used to do only the techniques for all of the patients. Still, we are doing the same technique. We are not adapted to non-gut. Well, we have not found any better results with that non-gut technique. What we do, we have to take some specific precautions while performing your anastomosis and your dissection. While dissecting pancreatic neck, what we do, we divide the interior part of pancreas from with the help of either diaphragm, coagulating diaphragm, or with the harmonic scalpel. But when we are close to site of PD, probable site of PD, we shift to cutting cautery or cutting diaphragm. So we try to avoid any thermal damage at that close to pancreatic second site. This is one thing which we again when we are doing this anastomosis, we have to be very careful regarding our anastomosis. That to be good anastomosis. We have to take precise suture with no cross of any suture. We have to be very thorough. We can use either this surgical loops or we can use headlights to get a better vision in this field. So this is one thing which I would like to quote.
Thank you. So it's the attention to detail and doing the same thing again and again. As you said, there is no difference in the incidence of CRPOPF between pancreatogastrostomy and pancreatoduodenostomy as shown by this RICOPANC trial. And also this systematic review has shown that there is no difference in clinically relevant postoperative pancreatic fistula. Either you go for ductal mucosa or other types of pancreaticoduodenostomy. And the PANASTER trial, that is the latest trial, showed that there was no difference in clinically relevant in postoperative pancreatic fistula, whether modified Blumgard was done or cattle Warner was done. However, this paper from Japan that was published in 2018, which compared invagination with Dr. Mikosa, showed that in a subgroup of patients who had soft pancreas, the clinically relevant postoperative pancreatic fistula was significantly less when invagination was done. So in surgery, I think we cannot be dogmatic. We need to sometimes individualize the technique as well. So to Dr. Sudeep Jain, like what is the have you been using stents while doing pancreaticoduodenostomy as a mitigation strategy?
So, and the stent is
Okay. So, as you said, it was initially shown that there wasn't much difference whether you use internal stent or external stent. And even the systematic review showed that there wasn't difference in incidence of clinically relevant postoperative pancreatic fistula, whether external stent or internal stent. However, in grade C fistula, the external stent was associated with significantly less incidence of clinically relevant postoperative pancreatic fistula. And in this randomized controlled trial from Verona group in high-risk pancreas, which was identified according to fistula risk score 7 or more, and the patients were randomized into pancreatogastrostomy and pancreatoduodenostomy with externalized stent. Although the procedure-specific complications were similar, but the average complication burden was less in those patients who had pancreaticoduodenostomy with external stent, and the major complication was also less in patients who had pancreaticoduodenostomy with external stent. So in high-risk anastomosis, external stent is said to reduce clinically relevant postoperative pancreatic fistula. So the third mitigation strategy is the use. There is so much of controversy regarding the use of drain in pancreaticoduodenectomy. So, Dr. Vikram Chaudhari, would you like to give us your opinion regarding use of drains in as a mitigation strategy for postoperative pancreatic fistula?
Yes. So in pancreaticoduodenectomy, at least in our center, irrespective of the fistula risk score or the risk of fistula, we prefer to put drains. And our preference is a Jackson-Pratt drain because it acts on a microcapillary action and doesn't get blocked easily. And we try to place two drains in two different quadrants. One is near the pancreaticoduodenostomy anteriorly, which goes towards the caudate, and another is in the Morrison's pouch, which also is pointed towards the caudate behind the HJ. So we try to drain both the areas. These are the two regions which we feel need to be drained. It's not only about the leak which may develop, but it's also sometimes the chyle and the postoperative fluid which needs to be drained for a few days. That's what we believe. But I'm aware of the studies where centers do not put drains at all, and they feel that the clinically relevant fistula, if it is going to become a POPFB, ultimately these are the patients who are going to require percutaneous intervention, and they will anyways need it irrespective whether you put the drains or not. But we have not dared to follow this strategy. There are very occasional patients where in absolute low risk pancreas, in a very straightforward patient, we might not have put a drain. But I think more than 95% of patients who undergo Whipple at our center, drain placement is a standard of care for us.
So we are also using drains routinely, two drains as you just mentioned. And there are various studies. So this particular study was done to show that drain is not necessary. But in this study, there was increased incidence of complications when drain was not used. And the Data Safety Monitoring Board terminated the study because the mortality increased from 3% to 12%. And what they showed was that if in patients having negligible or low fistula risk score, if drain is placed, then CRPOPF is high. And in those patients who have moderate to high fistula risk score, if drain is not placed, then CRPOPF rate is high. And this trial showed that the drain omitting drain was not inferior to putting a drain. And this study from multi-center study from US came up with the selective drain management. Drain was placed only when the fistula risk score was moderate or high, and depending upon the day one drain fluid amylase, the drain was either continued or removed. And when this selective drain management was applied, they found that the clinically relevant postoperative pancreatic fistula rate decreased from 20% to 11%. So now there is this risk-based drain management based on drain is placed based on fistula risk score and is removed based on the day one drain fluid amylase and also how the drain looks like. So it's not just the drain fluid amylase. We need to be careful about how what is the nature of the drain as well. So
Can I make a small comment, madam, here?
Yes.
Yes, I think now the data is in favor of drains, against drains. Both sides we have data, so it's confusing. But one thing is for sure, keeping the drains for a long period of time doesn't help. So even if you're putting drains, our aim should be to get rid of the drains as early as possible. The moment you see that the patient is not developing a clinically relevant fistula or the drains are serious, and the moment you see that the patient has no reason to have a drain inside, like there is no chyle leak or there is no suspected bile leak or no postoperative complication, I think the drains need to come out as early as possible. If we follow that, I think drain associated issues can be minimized. That's what I would say. Yes, thank you.
So another controversial topic regarding mitigation strategy for POPF is use of somatostatin analogues. So I would like to have the opinion of the Professor Yoji Kishi.
Thank you. Regarding this question, actually, we never use something routinely because there is no clear evidence that this was effective to prevent the fistula. So we usually do not use somatostatin analog nor protein kinase inhibitors.
So even I used to use octreotide routinely, but after this, I went through this study which was done in US, and so in this study they wanted to see the optimum mitigation strategy for high-risk anastomosis. High-risk anastomosis was those patients who had fistula risk score 7 or more, and in this study they showed that those patients who received octreotide had increased incidence of clinically relevant postoperative pancreatic fistula. 42% versus 19.9% in those patients who octreotide was not used. And the optimum mitigation strategy, as you can see here, is that the creation of pancreaticoduodenectomy, not using octreotide, and external stent in high-risk high-risk fistula pancreas was associated with least incidence of clinically relevant postoperative pancreatic fistula. So after this study, I haven't used octreotide. So just wanted to know what is there are various other mitigation strategies as well, but I just want to know what is the mitigation strategy from just be brief from each.
Actually, I think Dr. Rebala is there and Professor Sitaram is in the panel.
Okay.
So you can address all the questions meant for Dr. Pradeep to Professor Sitaram.
So, Professor Sitaram, what is your optimum mitigation strategy for POPF? What you can say?
I don't know whether you can hear me.
Yes, sir, we can hear you.
We can hear you, sir.
We don't use. I mean, when I was doing pancreaticoduodenectomies, I didn't use octreotide. I always placed a drain, single drain, right upper quadrant behind the pancreaticojejunal anastomosis. I didn't divide the pancreas with diathermy or with an energy source. I divided it with a knife and got control of bleeding with 5-0 polypropylene sutures. I know there's no evidence base to this, but I felt that cutting the pancreas cleanly with a knife and getting good hemostasis with sutures probably gets good vascularity at the cut edge. What else did you discuss? Drain?
Anastomosis.
Anastomosis, always a ductomucosa pancreaticojejunal anastomosis.
Thank you, sir.
my view, duct diameter, pancreas texture, and surgeon experience. These were the three main features which mattered. Thank you.
So I totally agree with you, and I think in the interest of time, we will not take the opinion of other panelists. We can discuss that later in the tea time. So this study which was done on behalf of Pancreatic Fistula Study Group showed that in high-risk patients, the optimal mitigation strategy was the making a pancreaticoduodenostomy, omitting the prophylactic octreotide, and minimizing the blood loss. So my question to Dr. Yoji Kishi is, when do you suspect development of postoperative pancreatic fistula, and what is your line of management besides the drain analysis?
Okay, so let me show you some slide I have made. I have made a couple of slides. So that on the screen.
So Professor Yoji has made some slides, so he wants to show slides.
Yeah, I have a copy.
Slide.
It's pretty so far. The management of POPF, not PCF, should be considered in the both in terms of intraoperative and postoperatively. And intraoperatively, the techniques of anastomosis would be a major concern, and postoperatively, the drainage method. And as other mentioned, drugs also are not routinely used, will be a concern. Next slide, please. And we think the drainage is said to be the most important issue. And then the timing of drain removal will be a problem. I got introduced by paper from one Japanese institution. We emphasize that not only the urine amylase level, but also serum CRP values, especially on postoperative day 3, because high CRP level, prolonged CRP level, postoperatively will be associated with a high risk of clinical level 1 POPF. So we use this criteria for the removal of drain. And if this criteria was not satisfied, we need to replace the drain tubes. And usually, as you also experience, if we put placement, if we place the drain tubes for a long time, initially, histography does not reveal any visualization in the pancreatic duct and small duct, just now. But after that, this last slide, yes, you can see the appearance of bowel after this. So I think this will be a sign that we can remove the drain tubes. So that's only this way. We manage the drain placement to treat POPF. Thanks.
So thank you. Okay. So actually there will be change in the course of the patient. Postoperative course will not be as expected. The symptoms will be non-specific, and besides the sinister-looking drain or elevated drain fluid amylase, there will be features of systematic inflammatory response syndrome with concomitant infection. And as Professor Yoji said, that the CRP will be elevated, the WBC count will be elevated, and it is very important to have the imaging to see whether there are any undrained collections or not. And it has been shown that the three important things in managing these patients is the drainage of the collection by image-guided drainage, either ultrasound or CT, or endoscopic ultrasound-guided drainage if it is in the lesser sac, and use of appropriate antimicrobial antibiotics, as well as the nutrition. And enteral nutrition is said to be superior to parenteral nutrition. And there are various suggestions that somatostatin analog also helps in the management of postoperative pancreatic fistula. So majority of the time, it's conservative management. almost 90% of the time, but sometimes these patients will require surgery. So I would like to ask Dr. Vikram Chaudhari, like, when would you consider surgery for postoperative pancreatic fistula, and like, what would you be doing during surgery?
So I think this is always a difficult decision to take in the postoperative period when you are dealing with the patient who has a likely to have a leak or a potential leak. The first thing which we need to do is avoid the denial. I think the biggest problem which happens after you do pancreaticoduodenectomy is a lot of people tend to be in a denial about the fistula being present. Every problem which happens after pancreaticoduodenectomy, unless proven otherwise, happens because of a pancreatic anastomotic leak, is what I would like to say. More often than not, as we know that the POP of B is a more common occurrence and a POP of C is a less common occurrence. Out of around 25% patients who are likely to develop fistula, around 17% of these 17 of these patients would be treated with a percutaneous drainage. Those 8% or 5% patients who are likely to develop POP of C, an early and a smart intervention is what you should look at. Do not delay the intervention when you see that the patient is not getting better after your percutaneous intervention, or if the patient is very sick to begin with. So if these two things are there, I think not being in the denial and an early swift exploration is what is likely to improve your salvage of that POPFC rather than a delayed intervention is what I would like to say. And your I think the center should be recognized by its rate, not of a rate of POPFC, because that generally should be at a high volume center around 5 to 8%, but your failure to rescue rate is highly important. And if you are rescuing more than 50% of your POPFC, I think you are managing your POPFCs better. So avoidance of denial, early intervention, and good rescue of POPFC patients is what I would suggest. I think technical things we'll discuss later if they come.
Okay. So yes, absolutely, as you said, and so these are the various management that can be done to the pancreatic stump at re-laparotomy, doing minimum just debriding and draining the peripancreatic region to completion pancreatectomy has been described. And the technique, a bridge stent technique, which has been described, is putting an internalized stent or externalized stent as shown in this picture, and draining the area of anastomotic dehiscence has been described, and versungostomy, making a controlled pancreaticoenteric fistula, cutaneous fistula, has also been described. So this was a survey that was done in 2013. It's a quite old one by EAHPBA, and they showed that there was major disagreements worldwide regarding the management of POPF, and they suggested need for standardization. However, the Dutch Pancreatic Cancer Group came up with this study of management of severe, means grade C, pancreatic fistula after pancreaticoduodenectomy, and they showed that the primary catheter drainage was associated with success of 77%, and in propensity score, propensity matched cohorts, they showed that the patients who had a primary catheter drainage had better outcome as compared to those patients who underwent primary re-laparotomy, emphasizing that conservative management with adequate drainage is the important thing in managing these patients. So there is much talk about going for completion pancreatectomy, and the same group came up with the study of multi-center cohort study and meta-analysis, and in this study they showed that those patients who underwent completion pancreatectomy had a worse outcome as compared to those patients who underwent pancreas preserving procedure like putting a drain, doing a versungostomy, or going for bridge stent technique. So the first thing in management of these patients with postoperative pancreatic fistula is adequate drainage, appropriate antibiotic, and the nutrition. Surgery is the last resort, and when you go for surgery, it's the pancreas preserving procedures, not completion pancreatectomy. So this is one of our patients who underwent who had ampullary carcinoma, and this is before 2021, And at that time, I used to do trunking pancreaticoduodenostomy. So as I said before, like this patient had normal drain amylase in day 3 and day 5. So we removed the drain early. But after that, she started to have her course deteriorated. And then on day 7, we did ultrasound, transabdominal ultrasonography, and a drain was placed, and the drain amylase was high. And then on day 10, she had a mild extraluminal PPH. CT angio was negative, and since her hemodynamic stability she was unstable, and then we took her for surgery, and where we did versungostomy and feeding jejunostomy. After that, although she had a prolonged postoperative course, she improved, and her pancreatic stent was draining around 200 ml daily, but suddenly it stopped. And then we did a pancreatogram through that stent, and what we found was that the pancreatic the dye was going not only into the pancreatic duct but also into the intestine. So it was like fistula was formed by nature. So I'm sorry, I did not find that picture of that pancreatogram, so I could not put here. And after that, we removed the stent and she was discharged. So there is a lot to discuss in postoperative pancreatic fistula. But as a take-home message, I would like to just share what high-volume pancreatic surgeons has to say. Professor Marcus Buchler has mentioned that we need to keep cool and not to overreact. 90% of the fistula will heal. Main problem with fistula is late bleeding, and which is the cause of mortality. Therefore, we need to be prepared for dealing with this bleeding, and interventional radiology should be available 24 hours a day and 365 days per year. And Professor Matthew Katz from MD Anderson also mentions that I almost never operate for fistula in my experience, and all fistulas can be managed non-operatively. And the surgeon from Argentina has he mentions that when reoperation is necessary for fistula, just drain the fistula by placing multiple drains, and make sure that you put a feeding jejunostomy and then wait and see. So the next complication is post-pancreatectomy hemorrhage, and this was also defined by International Study Group of Pancreatic Surgery, and it was in 2007, and it is defined on the basis of 3 parameters: onset, location, and severity, and this has been widely cited a paper. And so if the bleeding occurs within 24 hours, it's early. If it occurs after 24 hours, it's late, and it can be intraluminal or extraluminal, and it is mild or severe. So what is important to understand is the early is always grade A and grade B. Whether it's even the early is severe, it's grade A only, and the late is always grade B and grade C. Even the mild late is grade B, and severe is grade C. So, and various depending upon the various therapeutic consequences and clinical condition, also it is graded. And the severity is based on the fall in hemoglobin less than 3 grams, and also number of transfusions required. If more than 3 transfusions are required, it is severe. And based on the need for invasive intervention, also it is considered mild or severe. And this was the reappraisal of post-pancreatectomy hemorrhage definition. And what they showed was that the patients who had no PPH and grade A PPH had same outcome, and those patients who had grade B PPH, which will include early severe and late mild, have same outcome. But what they showed was that the outcome of patients with severe PPH alone, mild PPH with POPF, and severe PPH with POPF had significantly different outcome in terms of hospital stay and mortality. And they suggested that probably instead of time of onset, concomitant POPF should be included in the classification system or grading system. However, the definition has not been revised since 2007. So this is one of the case scenario. This is also a case which was performed before 2021, and he is a 30-year-old male with ampullary carcinoma and underwent Duncan pancreaticoduodenostomy. So he had early severe intraluminal PPH. And we did CT angio. There was blush in the pancreatic stump. Angioembolization was attempted, but bleeding was not seen. And since there was ongoing bleeding, we took him for surgery. And enterotomy was done proximal to the pancreaticoduodenostomy, and we could see the bleeder at the transected margin of the pancreatic stump, which was ligated. Feeding jejunostomy was done, and this patient developed postoperative pancreatic fistula, but was managed with adequate drainage, antibiotics, and enteral nutrition. So after that, he had uneventful recovery and was discharged on 35th postoperative day. So I would like to ask Dr. Sundeep Jain, would you have managed this patient differently? The case of early intraluminal severe PPH, and when would you opt for upper GI endoscopy?
So this particular case, which I will everything, but cases. So side answer was there, which was causing stable, but that
How early would you do in a post-operative patient where
majority of the cases it is not required?
So this is the second case scenario of delayed PPH. So this is a 30-year-old lady who underwent pancreaticoduodenectomy and Duncan pancreaticoduodenostomy. On postoperative day 3, her drain amylase was normal, and on day 5, she passed a little bit of melena, which was ignored. And on day 7, she had massive lower GI bleed and hemodynamic instability. And CT angio was done, which showed hemophilia with intraluminal blood. And angio in DSA showed there was bleeding from arc of Buehler. That's what our intervention radiologist said. And arc of Buehler is a communicating artery between the celiac axis and the superior mesenteric artery. And successful embolization with the gel foam particles was done. And she did not bleed after that, but she had pain abdomen and fever. So the first picture is the pre-embolization CT, where you can see clot inside the jejunum as well as the biliary tree. And the second one is the CT after embolization, when she had fever and pain abdomen. And there are two collections you can see. So one is this one, and the another collection is down there. And both these collections were drained percutaneously, and however, the drain amylase was not high, and she was discharged on 24th postoperative day. So this is another case of delayed PPH. This is a young female, 21 years old, who had an uncinate mass, and this was solid pseudopapillary tumor of uncinate process, and she underwent pancreaticoduodenectomy. She had eventful recovery till post-op day 5, and but on post-op day 5, she had melena, and she had hemodynamic instability, which improved with resuscitation. And CT angio revealed clots in jejunum, and DSA was done. So this is her angiography. And the bleeding was actually from the dorsal pancreatic artery, which was arising from the superior mesenteric artery. And our intervention radiologist embolized it, and after that, she had uneventful recovery. So since Dr. Pradeep is not there, I would like to ask Dr. Sitaram, would you have managed these two patients of delayed intraluminal bleed differently? And both of these patients did not have concomitant POPF.
The only thing I would add is we probably would have done an upper GI endoscopy. But otherwise, management of bleeds would follow what you have done. CT angio followed by angioembolization.
So in both these two cases, Duncan pancreaticoduodenostomy was done. So we were pretty sure that it was bleeding probably from the pancreatic stump. and we were a little bit reluctant to go for upper GI endoscopy so early on day 5. So that was the only reason we did not go for upper GI endoscopies in these two patients.
A significant proportion of patients bleed from the gastrojejunostomy as well.
Right.
Which have been managed endoscopically.
So here, I think both the cases, it was bleeding from the one, it was from the pancreatic stump, and the other one was also, I think, from the pancreatic stump. It was the arc of Buehler. So the third case, the third patient is he is a 65-year-old male who had ampullary carcinoma. So 40 minutes left. 40.
Chalo, take 10 minutes maybe.
Okay, so I will just discuss the PPH and then finish. So this gentleman had ampullary carcinoma and underwent pancreaticoduodenectomy. So on D1, there was blood in the drain.
Sorry.
Blood in the drain, and the patient was.
I think you have more time.
Patient was tachycardic, although the mean arterial pressure was maintained. And so, Dr. Vikram Chaudhari, what would be your approach in this patient? Actually, he had only extraluminal severe PPH. And what are the preventive strategies for PPH?
I'm very sorry, Dr. Lakhe, I couldn't hear you because there was some communication going on. So POD, 1 of PD, tachycardia, and fresh blood in the drain. Okay, blood in the drain.
In day
Okay,
one.
okay.
And this patient had modified Bloomberg pancreaticoduodenostomy.
I think this patient probably needs to be taken back to theater. If the patient is still stable, I sometimes would like to do a CT just to get an idea what is happening. But if the patient is unstable, on day 1, extraluminal bleed is usually a vascular mishap, a clip slippage, or a GDA, or a branch of SMA, or generally a technical problem which can be sorted immediately, and it is clearly an extraluminal. So I think I would take this patient for surgery. Sometimes if the patient is relatively stable, I might do a scan or occasionally an angio, but this is probably a surgical intervention is what I feel, first impression.
We did take him for a CT, and there was clots in the peripancreatic area, and we took him for surgery, and there was bleeding from the pancreaticojejunostomy site. And we did control the bleeding initially in the first surgery, but again he bled, probably because of coagulopathy, and he developed ARDS, and we could not salvage that patient. So what I thought was that we took him for surgery a bit late. We should have gone a bit earlier. So and what would be the preventive strategies for PPH?
Small point about the upper GI endoscopy, which Professor Sitaraman mentioned, is that probably the endoscopy is something which is done is when you do not get anything on other investigations, probably because it's will be very uncommon that the endoscopy will be a therapeutic endoscopy will be required after a Whipple. It happens, and a GJ, if you have done a staple GJ, sometimes that bleeds. But sometimes the CT first guides you what is the source. If it doesn't guide you, then probably invasive angio and the location of the clots and the extent of the presence of the clots, probably that guides us. And then we probably resort to endoscopy. So that was the only thing which I wanted to add. If Professor Sitaraman can add something else, I would be happy to hear what he says. But I think it's usually a CT depending upon the stability of the patient. Even if sometimes we more often than not, even if we plan an invasive angio, we still try to get a CT because CT is more sensitive and specific, and it gives a roadmap to the intervention radiologist also for their interventions. So sometimes more often than not, even if we plan an invasive angio or a DSA, we would like to do a CT angio in those patients before we proceed.
So do you have any suggestions for preventing PPH?
Okay.
Yes,
So you're probably trying to point towards the falciform the patches and the omental flaps, and but I think the best is the most common scenario when the PPH happens is POPF. So try to keep your POPF rate as low as possible. Be proactive in managing your leaks. I do wrap the falciform around the GDS stump in most cases. If I can't wrap that, if I have not dissected the hepatic artery for a long distance, sometimes I will just put it anterior to the GDA, just separate it from the pancreatic anastomosis. I don't prefer omentum. A lot of people I know prepare the omental flaps and put them anterior and posterior, but I think in the context of leak, if the leak happens, then that omentum itself sometimes gets necrosed and infarcted and infected, and that probably acts as a double-edged sword. So I'm not a great fan of omental flaps, but some people do that. Apart from that, a meticulous dissection and a meticulous surgery and a good hemostasis at the end of resection is what you can do.
Okay, thank you. As you mentioned, there are studies of falciparum ligament flap and even arterial reinforcement with the polyglycolic acid sheets have been described in the literature, which has shown to decrease the development of pseudoaneurysms and bleeding. So, however, we are not practicing these strategies. So this is an interesting algorithm where it mentions that whenever there is post-pancreatectomy hemorrhage, so if it is early, whether it is intraluminal or extraluminal, operative hemostasis is recommended. When it is extraluminal late, then interventional radiology. And if it is intraluminal and associated with even with POPF, then interventional radiology. If it is not associated with POPF, then interventional endoscopy is recommended. And when these strategies fails, then operative hemostasis. So this is our experience of managing around 336 pancreaticoduodenectomies, out of which the incidence of PPH was around 25%. And we categorize these patients into two groups according to the time zone. Before 2014, the angioembolization was not routine in our institute. So after 2015, you can see that PPH incidence is similar, 13.2 and 12.5. But what is significant is that after angioembolization, mortality has decreased from 58% to 23%. And this is the one of the systematic review which gives us the management according to ISGPS. So accordingly, grade A, conservative management, grade B, initially conservative management, then step-up approach to surgery early. And grade B is endoscopic or endovascular, and grade C, which will always be late, either endovascular or endoscopic, depending upon whether it is intraluminal or extraluminal, and surgery only when as a last resort. So as a take-home message, like we need to have a multidisciplinary approach in the management of PPH. There is no specific guidelines, but one need to go for individualized step-up approach. So I think that I have time. So the third complication is delayed gastric emptying, which was defined by ISGPS in 2007. And the definition is based on the need for NG2 for more than 3 days, the need for reinsertion of nasogastric tube due to persistent vomiting after postoperative day 3, or inability to tolerate solid diet after postoperative day 7. And it has been graded into grade A, B, and C based on these 8 various parameters. In grade A, actually can be treated with just prokinetic agents. And grade B, sometimes reinsertion of NG tube, and sometimes other investigation needs to be done, like GI endoscopy or contrast study or even CT. And grade C, like intervention, like putting a nasojejunal tube, draining the draining collections, doing surgery for delayed gastric emptying has also is considered as grade C. So, Dr. Daga, how often do you encounter delayed gastric emptying in your clinical practice after pancreaticoduodenectomy, and do you have any specific preventive strategies?
Our data, it's around 11%. 11% of our patient had this delayed gastric emptying, and less than 1% patient had this type C disease among those. So this is our data so far. Regarding prevention, in our setting, foremost cause of disease again POPF. So we try to prevent POPF as far as possible. And after POPF, other is our GJ technique. What we do, we do GJ in infracolic compartment. We do a classical impulse and do GJ in infracolic compartment. It's a anti-peristaltic GJ. So what happens when we keep it in infracolic compartment in a retrocolic fashion, not anticolic as against other data. We keep it in retrocolic fashion. So stomach lies straight forward. So somehow gravity helps in pulling of food into the jejunum. Further, we separate infracolic and supracolic compartment. So if any leak happens, it is limited, inflammation is limited to upper part, and this GJ muscle is not affected by this inflammation. Further, with anticolic anastomosis or GJ enteral, this apparent limb of GJ is on the left side, is far away from the probable leak site and probable inflammation. So probably this may help in GJ over setting.
So, various preventive strategies like pancreaticoenteric variation in pancreaticoenteric anastomosis, going for pancreaticojejunostomy or pancreatogastrostomy has been evaluated, and various studies have shown that whether you do pancreaticojejunostomy or pancreatogastrostomy, the incidence of DGA, there isn't much difference. But it is said that pylorus preserving pancreaticoduodenectomy is associated with increased incidence of delayed gastric emptying as compared to pylorus resecting or stomach sparing pancreaticoduodenectomy. That's what we've been doing. And regarding the technique of reconstruction, as you mentioned, literature suggests that anticolic is preferred over retrocolic. And it has also been shown that doing a bronze jejunostomy also decreases the incidence of delayed gastric emptying. And this is the PODA trial done by the Spanish group, where they compared Billroth 2 gastrojejunostomy with Roux-en-Y gastrojejunostomy to see whether delayed gastric emptying is decreased or not. But they found that the incidence of delayed gastric emptying was similar in both the groups, and they said that probably Billroth 2 is favored because it does not require an additional anastomosis. So the next question is, how would you approach a patient who developed delayed gastric emptying? Dr. Professor Sitaram.
We used to do feeding jejunostomy for all our patients. So if there is delayed gastric emptying, it really is not stressful because we have a way of feeding the patient. So we just sit it out.
Okay. So these are various ways. The first and foremost thing is that we need to rule out mechanical cause. Endoscopy and sometimes even dural meal or gastrogastrin meal is required. And definitely intra-abdominal collection needs to be ruled out because most of the time it is associated with postoperative pancreatic fistula. So, so this is one of our case. He is a 69-year-old male who had duodenal carcinoma of the and if you see in the imaging, he had portal cavernoma as well. And this portal cavernoma was not associated with portal hypertension. So after extensive discussion, we took him for surgery, and we could save one of the collaterals and do pancreaticojejunostomy. As discussed in the morning, in this case, we transected the bile duct in the end because it had got a few collaterals, and we used a vascular stapler to transect the bile duct. And in the he had only eventful recovery, and he did not develop postoperative pancreatic fistula, but we were unable to progress with feed, and he had hiccups with bile reflux. And we did upper GI endoscopy, and we could see patent anastomosis, and CT did not reveal any collection. And barium meal showed, this is actually gastrogafin meal, which showed that we could see in 30 minutes the dye was going into the jejunum. There wasn't any mechanical cause of obstruction. So this, we do not routinely make a feeding jejunostomy. So this patient, it was really difficult managing this delayed gastric emptying. However, the radiologist, interventional radiologist, kept a nasojejunal tube, which were, and we could feed the patient. So, what would be your approach in patients who have delayed gastric emptying but do not have postoperative pancreatic fistula?
Actually, recently we have very rare cases with grade C disease or the patient who cannot eat for more than a couple of weeks. So, in usual manner, it would be sufficient to manage the patient only with intravenous nutrition or direct nutrition. But I think we have nothing to but to wait until the bowel movement recovers, and especially previously we put enterostomy tube routinely in all cases we put procedure, but recently not because as I mentioned, we have very rare cases with DCD, but in patients with especially in the elderly patients in which the post of malnutrition will be a major concern, I recommend to put the enterostomy tube into the.
So this patient did not have bronze jejunostomy, although my colleague is here, he routinely does. And after a few very distressing delayed gastric emptying, I've also started doing bronze anastomosis, and I think the incidence of delayed gastric emptying in complicated cases has pancreaticoduodenectomy has decreased. So it is not a very common complication. And technical improvements like pylorus resecting or stomach sparing with anticolic gastrojejunostomy is recommended. And bronze anastomosis has definitely shown to decrease delayed gastric emptying. We are not using feeding jejunostomy routinely, and I think it needs to be individualized. So the fourth complication is post-pancreatectomy acute pancreatitis. This is the new entity, and it was defined by ISGPS in 2022, and it is said to be associated with increased complications, especially it is post-operative pancreatic fistula. Although ISGPS defined it in 2022, it was first described by Saxon-Corner in 2016, where he defined post-operative pancreatitis as elevated serum amylase more than the normal institutional value. Just more than the normal institutional value. And he recommended using, based on CRP, it was predicted to be grade A or CRPOPF based on CRP. And according to the change in management or requirement of intervention, it was further graded into grade B. And when surgery was required, reoperation was required, or when there was mortality, it was graded as grade C. The ISGPS defined post-pancreatectomy acute pancreatitis as those patients who have sustained hypoamylasemia, that is, serum amylase is elevated more than the institutional value for at least 48 hours. And these patients are said to have post-operative hypoamylasemia. And if these patients have radiological evidence of acute pancreatitis, clinically relevant change in management, then it is graded as grade B. And if the patient has organ failure, persistent organ failure, either single or multiple, or patient needs surgery, or patient dies, then it is graded as grade C. So if you look into the Saxon-Corner's definition as well, like requirement of intervention, surgery, and as well as according to ISGPS, the treatment of post-pancreatectomy acute pancreatitis will be same as that of post-operative pancreatic fistula. So management will not be different. We will not be doing different management in post-pancreatectomy acute pancreatitis. It will be same as that of post-operative pancreatitis. So as you can see here, same thing, biochemical features. If it is serum amylase is elevated for more than 48 hours. And if radiological features are there, it will be either grade B or C, depending upon what is the clinical impact. So this clinical impact will be same as that of POPF. So I would like to ask Dr. Vikram Chaudhari, what is the how practical and relevant is post-pancreatectomy acute pancreatitis in our clinical practice? And being a resource-limited country like ours, can we omit radiological features to define acute pancreatitis in these patients?
Yes, so I think I would just say what we do at our institution. So day one serum amylase is what we are doing currently. Usually it is done on the next day, the second day. So it means it is around 24 to 36 hours since the surgery. And that's the time where we try to do that. And if it is significantly raised, I would not say exact value which we follow, but if it is more than a drain amylase or if it is significantly raised, we would think that this patient has developed a pancreatitis. But I think one of the important indicators of development of postoperative acute pancreatitis is also on table sometimes when the pancreas develops white patches and there is a stranding around the pancreas in the pancreatic capsule. If you see the white patches developing, these are the patients, and the patients who have high fistula score, these are the patients who probably in postoperative period likely to also have postoperative acute pancreatitis as a component which results in their postoperative complications. Radiologically, if you ask me, we also do not do CT scan as a standard of care to diagnose a clinically suspected postoperative acute pancreatitis, but more often than not, these patients have issues in postoperative period and they end up getting a CT scan on day 4 to day 8. And that also tells us radiologically that these patients have coexistent pancreatitis, which has resulted in a fistula or some other problem. And that's how most of the times we get both the biochemical evidence and the radiological evidence. But just to suspected postoperative acute pancreatitis, if the patient is otherwise doing well, we would not do a CT scan.
Less than 5 minutes.
Sure. So I think then we will take questions from the delegates. So this study showed that even the definition of hypomylesemia is still evolving, because this study showed that out of 247 patients, 165 had hypomylesemia at day 1. And only 24 patients had persistent postoperative hypomylesemia as defined by ISGPS. And if you look into this diagram, like those patients who had postoperative hypomylesemia, that means elevated till 48 hours, only 9 patients had CT evidence of acute pancreatitis. Whereas those patients who had hypomylesemia in day 1 had almost all patients had CT evidence of acute pancreatitis. So this is our study. Like in 135 patients, we looked into the postoperative hypomylesemia, and what we found was that the 52% of our patient had postoperative hypomylesemia, and clinically relevant postoperative pancreatic fistula was significantly high in these patients, and mortality was also high. So what I think is that although post-pancreatectomy acute pancreatitis is a significant entity, does it really have any clinical implication besides the post-operative pancreatic fistula is a big question, and the whole entity is still evolving. So we need more studies to establish this entity. So I have so I'll not
finally, but CT scan is the only thing probably which will be conclusively diagnosing the pancreatitis in the postoperative period. Everything else will have a biased interpretation. That's the problem. So this definition will evolve.
So that's what I wanted to ask, because you discussed that whether CT is required or not. But in most situations, clinical picture. In most situations, the clinical picture will be as if something is happening. And as Vikram rightly said, after PD, if something is happening, you have to rule out a leak. The only way that you can rule out a leak and collection is by doing a CT scan. So I think for all practical purposes, a patient who is not settled after PD, cost is a constraint, but I would say that a CT should be done.
I think the biggest problem in the management of post-pancreatic complications is surgeons' denial, is what I feel.
So any questions from the audience?
Another question I would like to ask everyone on the panel as well as in the audience: has anyone ever operated on a patient with DGE, and what is the maximum duration after which you have seen a DGE settling?
Yeah, never.
The maximum, maybe Ashok could remember, we have seen is more than 5 weeks or 6 weeks
this patient, and then it's settled. Another thing, which is an observation by the residents, that whenever we wanted to exclude a mechanical cause and got an endoscopy done, somehow after endoscopy the DG resolved. So probably it was not DG, it was some kind of a kink at the gastrojejunal anastomosis or the duodenojejunal anastomosis, which got corrected by the scope passing through the stoma. So that is an observation made by many residents and in many cases.
So we also have the similar experience.
So it's not an Indian phenomenon only.
Yes, sir. Almost it's a protocol now at our center that if the patient's DG is not settling for 2 weeks, third week we are doing an endoscopy electively.
Yeah.
But we try to wait for 2 weeks usually before we do endoscopy.
I remember there was a discussion actually in between. I am doing some administrative work also related to JSF, but there was a discussion that delayed intraluminal bleed. Now, early intraluminal bleed agreed that endoscopy should be done, but if you have a delayed intraluminal bleed, say after 7 days, 10 days, then what should be done?
You can just wait, it's very to rule out anastomosis ulcer.
Sir, endoscopy has a limited rules, and as was mentioned earlier also, it is usually the investigations when all the other investigations were done and nothing was found, then we end up doing endoscopy to find out if there is something inside like anastomotic ulcer or something which is causing problem.
But yeah, the counter question is that could a delayed intraluminal bleed be a manifestation, say, of a small collection eroding into vessel, which instead of rupturing in the abdominal cavity has ruptured into the loop also?
Definitely, the pseudoaneurysm usually, whenever there is a pseudoaneurysm, they have a tendency to, sometimes go intraluminally through the anastomotic line and present as a intraluminal bleed, though actually they are the extraluminal streams.
So there will be evidence of extraluminal bleed also in those subset of patients.
Yeah, I just wanted to say that in our practice, we put in a nasojejunal triple lumen tube in all patients during surgery. So it's a triple lumen freca tube. One lumen will be in the stomach. The other jejunal limb will be in the efferent limb of the GJ. And we keep it for about a week. And if there is DG, the gastric port will decompress it. If there is none, we remove it by 5 to 7 days. We found that quite useful. And we don't do a feeding jejunostomy like you.
So I'm Dr. Dheeraj from Jaipur. So anyone has experience of erythromycin in DG? Because we had a patient of grade 3 DG which was up to 3 weeks and was not responding to all the prokinetics. But adding erythromycin, he responded well to that and proved well. Yeah.
Kapoor sir, can I make a statement?
Yes. Yes, please.
I really don't believe any of these drugs which are used as prokinetics in the post-op period, if they really help the relief from DG. I really have no confidence in any of these drugs. I don't know what the other panelists feel. I think the DG takes its own time to resolve. If the fistula is treated, it resolves. And sometimes if it is a primary DG, it resolves on itself after some time. I have no confidence or any drug.
I would like to make a comment actually. In our practice in Rajasthan, we are mostly a vegetarian patient with somewhat long colon. So we are using this Lesodite since 2018 in all our patients on day 3 or day 4, starting from day 3. And what happens, DG is often contributed with the colonic or small ileus. So I think that part being taken care of with this Lesodite, and this somehow reduces the DG. This is what we feel in our practice.
I don't think that's available in Nepal, but we have been using erythromycin with sometimes it helps and sometimes it doesn't. So this is our experience of 181 pancreaticoduodenectomy at our department in last 5 years, and our POPF rate, CR POPF rate is 22.6%, and this DG is 5.5% with mortality of 8.8%. So before I conclude, I just want to mention this Porsche trial from Dutch Pancreatic Cancer Group, and they have come up with the mobile app where you can feed all your data in that app. We can download it, and we can and where all the data can be entered, and that will give us the whether CT is recommended or not, whether So for us, we routinely give antibiotic. They also mention that whether antibiotic needs to be given or not, and even it tells us when to remove the drain. And it also helps in evaluating the CT scan that is done in the post-operative period. And implementing this algorithm or this sort of AI, they showed that the primary composite outcome was significantly decreased in the intervention group, as well as the bleeding and the new onset organ failure also decreased. And the postoperative procedure specific complication, there wasn't much difference, but the failure to rescue decreased from 15% to 8%. So those patients who developed complications were identified early and was managed appropriately. So, and that smart app has been validated by the surgeons in UK, and they also showed that it helps in improving the post-pancreatectomy outcomes. So, as a take-home message, that complications are part and parcel of any surgery, and reporting of these complications are important. And it is important to anticipate the complication, identify it, and act promptly. And there has been shift in management of complications as we go for step-up approach, and the importance of multidisciplinary management for good outcome cannot be undermined. Thank you very much.